Well, hello, I'm Helen Elliott, and I've been working with the 2gether Trust. Where's Louise gone? With Louise, wherever she's gone, on the smoke-free sort of agenda. Okay, so we've talked a little bit about the reasons why we should be supporting our service users to quit smoking. And in the Trust, we've been working on this sort of journey for quite a long time. About 10 years ago, I think there was a sequence about the numbers of service users referred to get support, and you had to hit a certain level to receive some of the money that was already allocated to the Trust, but for it to be released for us. That's sort of where we sort of started looking at it. But through various conferences where we heard a lot of the information that's been shared with us this morning, we wanted to really engage with our services to see, could we become smoke-free? How would it work? And what are people's thoughts about that in our organisation? So we held a smoke-free stakeholders event in November 2014, and that was held at Montpellier Ward, and included a range of stakeholders, including staff, service users, carers, and a range of people from around the Trust. And following that, the sort of presentation was done by myself and Lawrence and someone from the local smoking services. Lawrence, sorry, is an expert by experience. People were very impassioned, really, about what we were able to share, and agreed to move forward with looking at a nicotine management steering group, we've sort of called it then. And that was established in January 2015 and included our experts by experience and the local stop smoking services. And one of the things that was really helpful, which has been mentioned earlier on, was the NICE guidance from 2013, page 48, which gave a sort of self-assessment tool, which we Kazim mentioned earlier on, I think, where you plotted how far you'd got and what your services were like and where you'd like to get to using a spider graph. But as on its own, it didn't really seem to go very far. We talked about all the reasons why we wanted to do this piece of work, all the benefits, but unless we had executive sign-up really to move forward, we couldn't really get very far, which is one of the things that we shared earlier. So following executive sign-up, we set up the Smoking Cessation Project Board, and we had project management working with us to make sure we moved at a progressive pace. And as we mentioned already, we went up to smoke-free in 2017. It's been a bit of a journey for us, obviously, to get to where we are. We're not where we want to be yet, but we're still on that journey. So I just wanted to share a few of our sort of overall successes and challenges, really, not the whole lot, because we could be here all day for all of those. But as quit advisors and smoke-free champions, we have had lots of successes, but there also have been some challenges. So some of the successes in setting up the Smoking Cessation Project Board is that we've got a smoke-free policy about how we would implement smoke-free in our organisation. As already was mentioned, I think about Alison, the Hereford phase of smoke-free only went smoke-free in January this year. And part of our success as well was around having treatments in place, systems, communications and training, having all those aspects in place as well as a few other areas. And we trained a lot of quit advisors and made sure for inpatients that they're present on all the wards across Gloucestershire and Herefordshire. We've got 2 inpatient units in Herefordshire and then a few over in Gloucestershire as well. One of the areas that I've been sort of a bit more involved with is around sort of the training element recently. So what we wanted to do was to work with every member of staff to enable them to give brief interventions to understand why we want to go smoke-free, the physical effects of smoking, mental health and those sorts of issues. We've delivered just over half of our inpatient staff in Gloucestershire and 25% in Herefordshire. Looking at the rationale for brief advice, NRT and vaping, and we talked about e-cigarettes earlier, and I sort of used the word vaping here. And in the community teams, we have quit advisors in a few community teams. We've got a few quit advisors here, Inga and Liam and Lisa and others. And we have started to roll out some level 1 smoking cessation training across the community. So just looking at a few of the challenges, we can't look at all of them in the time that I've got. So one of the issues is, as mentioned earlier on, is that some patients are still smoking in the gardens. This is mainly sort of the acute areas, acute inpatient wards, where you haven't maybe got so much control on access in terms of sort of low secure unit that we've got. And that has been a little bit of an issue. There's a lack of staff confidence to approach patients to say, actually, we are smoke-free, this is what we can do to help. And one of the other issues is that some of the patients are just moving off the site to smoke on the road or in the public areas, which is quite obvious to other patients that we've got in, and then easily taken up, not really looking at the health benefits of quitting smoking. Inpatient staff, we talked about treatments. We've got a system where NRT is offered off the approved list, so it doesn't need a patient group direction. All nurses can administer from that, and we are able to give that for the first 48 hours before it can become written up on the drug chart by a medic. And so that's a really useful tool, but it's not always used. There are some vaping policy challenges, which is one of the things we're sort of looking at the moment, because it really is a very helpful tool for service users. And we are allowing vaping in our gardens. It's just not the smoking element that we're not allowed to. There's been some lack of face-to-face engagement. Would you agree in terms of level 1 training, and that we set up quite a few sessions and people aren't necessarily coming for a range of different reasons? And that delivering training is actually quite time-consuming if you're going to set it all up, turn up, and then you have one person, and so that's not really helping. What is helping us at the moment is we've got a sequin, and the sequin which was mentioned earlier on about smoking cessation and alcohol reduction, those sorts of things. But I think it's a challenge to get to that, and Louise would vouch for that. So some of the steps we've taken to look at trying to address those challenges. Patient smoking in the garden, as we heard sort of earlier on, people's perception is that if you challenge somebody to smoking, there's going to be an aggressive incident, and your staff don't want to put their relationships at risk because of addressing some of these issues. And of course, as a mental health trust, we want to put safety first. But it's about looking at risk assessment, individual care planning for that person. How can we help to move forward? And some things that mentioned earlier on about engagement and trying to work with what works for them is really, really important. Patient smoking at the roadside, well, we want to try and implement a positive approach. What can be helpful and not just what is not allowed. And this is why we like the smoke-free, in some ways, presentation for smoking cessation, because it's not do not smoke. Because if you say to smoker, do not smoke, the first thing they want to do maybe is go and have a cigarette. So it's really about saying, to be free from the chains of smoke. And I'm an ex-smoker, and I feel that, that now I don't smoke at all, I am free of some of those chains. But it's about regular discussion about smoking status, the support available, NRT, and vaping, and having some, giving background on that. Lack of confidence, well, we've looked at good news stories. Our comms department have been really helpful in sharing those stories across the trust. We've also developed, and I'm really sorry we haven't got that here at the moment, it's a little card like this, which has got our Smokefree emblem on it, and it sort of says, you're not allowed to, here are some help, and so here are some places you can go to get help to manage your nicotine issues, and that we don't smoke in our premises. That's as a way to start it. And that was sent out to all the quit advisors recently, and I apologise for not bringing one to show you. The other issue around lack of confidence really is clear leadership from the people in charge of the shift, from the managers and from the matrons, certainly in the inpatient hospitals, because we can't implement this. It has to be implemented at a ground level, it has to be owned, and so we've got some really good evidence of that started to happen, but we haven't got there yet, totally. And I think the lack of engagement, we're trying to look at that in a different way. So we would really send in some more corporate people to come and run some of the sessions, and then the lack of attendance is an issue. So what we're trying to do now is to look more at local people doing local training. So in our single recovery units, we've got quit advisors there, and we've got a training program to share with them. We meet with them and look at how they can do that training. They can do it on one-to-one or run a session. In Charlton Lane, our older person service, I met with the quit advisors last week, and we've looked at a program of how to work there through with that, which I think is going to be really helpful. But we're constantly evaluating how that works in terms of our figures. And part of that really is to make sure we're again promoting NRT and vape information. Our other area really to look at training is we're considering an e-learning package. We know face-to-face is the most effective way to sort of change culture as well, but there comes a point when we can't keep rolling that out all the time. So we have looked at an e-learning package that we can purchase from a company, and looking at funding that, and that gives all the background without having to have a face-to-face session. You can do it in your own time, and we'll also have a mechanism for measuring who has done that to make sure that it's rolled out, and that is very clearly around brief interventions, asking the 3 A's, and all those sorts of things we've heard of today. So I just wanted to mention just briefly about vaping. So as I said, vaping in our smoke-free policy is allowed for service users, and to be encouraged if people don't want to necessarily quit, but also if they do want to quit, because there's recent evidence to say that it is a tool that helps with quitting. In our hospitals, it's either about temporary abstinence while you're in our service, you don't smoke, and also leading to quit attempts. And referring people onto that. So we've got a proposal, which is, has anybody heard about the e-burn vapes? Yeah, so they're available in Low Secure, Unit 136 suites, those sorts of places, and they're endorsed by the NHS. Would that be the right way to say it? Well, they use it in a lot of NHS places. So the paper's been written to run a pilot on Kingston Ward in Wootton Lawn, and the proposal really is about e-burn vapes being provided free to people when they come in for the first 3 days of admission, and that each vape is equivalent to 30-35 cigarettes, and depending on how high your addiction level is, that should keep craving a vape for 3 days. In the meantime, that gives us a chance to look at other projects and other prescribing for NRT, but you can vape and use NRT. Having a patch will help to reduce the overall nicotine cravings, but also the vapes hit the brain so quickly. It's the clearest, the closest sort of mechanism we have to smoking. People will know that in the cigarette, it's not the nicotine that causes you to lose so much of your life expectancy, but it's all the carcinogens that are in the cigarette. And there are lots of poisons, arsenic, all sorts of things in there. But you don't get those if you use a vape. It's clean. It's clean nicotine. And we're going to run that in a PDSA model for improvement and test it out on a small scale on Kingston Ward. And then we will review the outcome. And once we've learnt the lessons from that, we will start to roll it out. We're really quite interested in what everybody else is doing about vaping and e-cigarettes, and hopefully there'll be a little chance for a Q&A session later on. And then here's our little logo. I do like this. So smoke-free is a journey, not a destination, and we are making that, travelling that road with the support of all the people available to us, but primarily our service users. That's it. Thank you very much.
I'm Vukile Bila. Most people call me VB, which over the years has helped to speed up business with the locals because they find my name very, very difficult to say. I'm a staff nurse at Montpellier unit, and my colleague Lisa Devon is the team leader for what we call the EAP team, which stands for Engagement and Exercise Practitioner. I'm not going to try and steal the glory, because when things become very exciting, many people want to be associated with good things. I've been more in the background over the past few months, and I have to admit, Lisa has been the champion of the smoke-free revolution, if I were to call it that. My role is very simple, just to tell you briefly of who we are as a unit. Montpellier unit is part of 2gether NHS Trust. Some of you will remember what used to be called the Gloucestershire Trust. But when we took a business approach to work, we kind of dubbed our name so that it becomes a little bit more business-like. Hence, we are called 2gether. Montpellier unit is a 12-bed male law secure unit. In essence, when it was built, the admission criteria was that one needed to have an enduring mental illness as well as having committed an offense. So most of our catchment group was the prison area. But over the years, we have also included people we normally refer to as revolving door patients. We identify these from the main hospital just to give them a prolonged period of treatment in a secure environment. When we do what we have to do with the patients, the aim is usually to discharge them into community, get them more independent into some accommodation. But in rare cases, instead of going down the ladder, when we fail to achieve what we would have hoped to achieve, they end up going back to prison in some cases, and in some cases they go back to medium secure. Mostly our clients are 18 to 65, that's the age group, and initially we excluded people with personality disorder and brain damage. But again, over the years, things have changed. We would get occasionally some of these cases that were excluded in the past. As a unit, from a nurse's perspective, before the Smokefree Journey started, we used to run almost a daily appearance in the garden because everybody was in the garden smoking. And by the time we left, I don't smoke, by the way, and I'm very pleased to say that. By the time we left, you would obviously be smelling of cigarettes. And the garden was manned by a member of staff. We had allocations every hour. So throughout the clock, we would have a member of staff in the garden and patients are going in and out. That was the culture then. And then after midnight, we would open every hour, like 15 minutes every hour. And then we would close the garden just for brief periods during handovers. At that time, patients had their own tobacco in their rooms and they kept their lighters in their rooms. And there was also another unmissable big lighter mounted in the garden. And each time patients went on leave, they could smoke as much as they wished. That was then. And I will now give Lisa a chance to tell us exactly what has happened in the journey to smoke-free. Thank you.
Okay, so before we went smoke-free, we kind of looked at what would be the best approach to take. So we actually adopted a systems level approach. So there's a lot more research coming out lately that actually a systems level approach is the best approach to change health behaviours. It basically just looks at all aspects of the system, and the system in our case was the ward, and I suppose the wider hospital would change, potentially echoing through the system. So one example is before our patients come into the hospital, we try and let them know that we're smoke-free. So hopefully they'll have started using a vape or already on an RT before they come to us, making our job less stressful when they arrive. Mental health settings, obviously they're very complex settings, and this type of an approach is very, very good to use within a mental health setting. Another thing that really helped us is we had a sequin a couple of years before we went smoke-free, and that kind of got everybody looking at it. So it wasn't just the quit advisors or the people championing it on the ward. It got noticed within the senior management, which kind of got them more involved and more willing to, I suppose, take on things that we were suggesting. So smoke-free for us is not smoking in the garden, but if the patients have leave, they're able to go out, have leave off the grounds of the hospital, they're with a staff member or they're not with a staff member, they can then smoke. The reason we chose this is that we got feedback from our colleagues within other low secure units. They had implemented it where on escorted leave patients weren't able to smoke. Some patients challenged it through the courts, they actually won. So we kind of went, we're meeting halfway. We're not going to just kind of enforce all this. Let's just start with this and then see where it takes us. So at the start, we gave out surveys to all the staff and service users, just to kind of get their opinions and views on what they thought or what they were expecting or what a smoke-free unit would look to them. And that actually proved really, really helpful in the beginning. Everybody felt like they were being listened to. We added on to all our meeting agendas. So the staff meeting happens every 2 weeks, community meeting with all the patients once a week. Our Montpellier referral form got changed. So anybody being referred into services, there was a box where you had to say if they were a smoker and roughly how much they smoked. As well as that, we're quite lucky to go and assess our patients before they come in. So whoever goes and assesses, who's usually some of the senior staff, they need to start asking, are you smoking? Do you know we're smoke-free? This is what we can offer you when you come to us, but you could get started with it before you come. We added it to our supervision agendas with all the staff, and we discussed it in our handovers as well. Lighters became a prohibited item, so we did that about 3 or 4 months before we went smoke-free because we knew it was going to happen anyways, so just kind of took the edge of it all happening together. We did it a few months before. And it was kept in a locker, belonged to the patients in the ward clinic. We started off with weekly groups, so staff and service users were invited. It was a way of them kind of raising any of their issues and concerns. As you can imagine, a lot of our patients weren't happy, and staff were not happy about it. So they were able to raise those concerns in that constructive manner. We kind of collected initial thoughts and ideas from staff and service users in the groups, what they'd like to see. We looked at the benefits to physical health, what would help them with the transition, looked at budgeting, made it personal. Our patients get benefits, a lot of benefits. Some of them spent it all on cigarettes, but actually one of our patients was really into his trainers, and it's actually, well, you could buy 2 pairs of trainers with that money that you're spending in just the week. And it's just making it personal to them so they could actually really see for themselves how it could help with them. And we discussed the withdrawal symptoms. So we had 2 staff trained as level 2 quit advisors. Unfortunately, one left and the other didn't complete the training, so we only had one, which was me. We did consider level 1 training for the service users who were going to be on the ward before we went smoke-free. But unfortunately, we had 2 people identified and they got discharged before we went smoke-free. But one of them massively championed vaping and got kind of everybody else trying out his vape, and then led to them purchasing vapes. And another one wasn't a smoker and was very, advocated for people not smoking, but unfortunately they had gone before that. I think we got about 90% of our staff trained to level 1. We did it at an away day, so it was an easy way just to target everybody. They had no choice. They were there. They had to listen to what we said to them. We looked at doing some garden upgrades, and the patients and the staff were involved in that. They gave ideas. Some of the patients actually drew out sketches of what they would look at, what they would look at it. What it would look like, and we sent letters to all the patients and carers. So the carers were aware we're going smoke-free. If you've got any questions, any concerns about your family members, then please contact the ward. We'll discuss it with you. And the letters to the patients, they got given letters at the start. They were given other letters that highlighted what we were planning as well, which some read, others probably just chucked them in the bin. But it was just another thing that we did just to try and help. We had a smoke-free folder available to the staff, so that had information on vapes, it had information published from Public Health England, and information on NRT as well. Before we went smoke-free, it kind of came in across the hospital that there was 4 NRT products available in the medicine cabinet, so it's in the store cabinet, and that's a stock item. So if we've had this problem in the past where patients wanted a patch, we have to go down to pharmacy, we have to get it rolled up, it's just a palava, and then they change their minds. So this is something that really, really helped us. There's always NRT products in our clinic. Every patient had a stop smoking plan. And as well as that, we support them to purchase vapes. Obviously, we can't advocate saying this vape is better than that, but if somebody didn't have leave off the ward, maybe they were a prisoner that was transferred, or they were under the Ministry of Justice, we would say to them, we'll go get you a starter one. They'd give us the money. Or for some of our patients, they don't have any money when they come in, they've got no family, they've got no benefits, and right or wrongly, we would apply to a social fund that's available within the trust to buy them a vape, which they would then, once they got funds, they would then pay back. We monitored the assay bloods closer. The majority of our patients are on clozapine, and obviously that was something that we needed to really, really look at, not just when we went smoke-free, but in the lead up to it, because many of the patients had cut down on the amount they smoked. And we had an amnesty the weekend before we went smoke-free, so we actually didn't say hand over the tobacco. We just said, if you get a chance, can you just hand it in over the weekend? And the tobacco was going to be stored in our airlock, so off the ward, and they could get it on their way out. Which every single patient handed it in. We didn't have to go and ask anybody to give it up to us. We did a reduced access to smoking in our garden, and this is one of the things that a lot of our patients found really, really helpful. And they were the ones who helped plan this. So they were the ones who said, okay, rather than going from smoking, like Phoebe said, all day, every day, we cut it down to 10 minutes on the hour. And then they said, how about 10 minutes every 2 hours? And vaping was allowed. So it's important to notice when we did this, we had a cigarette lighter in our garden. We had patients who held their own tobacco, and we didn't have one incident of patients going out in the time to vape that was allocated. So 10 minutes to smoke, fine, come back in. We had 50 minutes where they could vape. Not one patient went to that wall to light a cigarette. And I think that's just all the work we had done previously with them, and they knew it was coming. So they all cooperated with that really, really well. Everybody got a smoke-free bag. It's just little gimmicks and just things trying to promote it. So the week leading up to smoke-free, one of the things we looked at is that actually patients put on weight. And what we said was actually, well, if you're going to put on weight, let's try and limit it. And let's look at what's kind of healthier snacks that you could go for. So we gave them ideas of that. So there's, healthier cereal bars, popcorn. There was information on smoke-free, about going smoke-free. We gave them stress balls. There was yo-yos. All sorts of little bits and pieces in there, and sugar-free mints. As well as actually something that one of the earlier presenters said about the activities. We didn't have remote control cars, but it's something that we overlook in our ward because we've got such a good activities programme that actually we didn't even think that we were just doing that already. But that is another thing that probably did contribute to it, getting everybody involved in either groups or on a one-to-one basis. In our first week of being smoke-free, we provided extra fruit on the ward because we knew people were just going to be wanting to eat toast, cereal, the kind of things that are readily available. We made up some healthy yogurt and granola pots, which went down a treat. And we also had sugar-free mints just lying around the ward as well, so patients could have them, especially after meal times, because that's when a lot of them said, I need a cigarette. So in our first week of being, when we started being smoke-free, we put on extra relaxation groups. That was run by our psychology assistant, and that came from a patient. A couple of patients said, we'd really like that if we could, because if we're feeling stressed out, we can just go. So I think we went from having that once a week up to 3 times a week, and that lasted maybe only 3 weeks, but if the patient said, no, we're actually okay now, we don't need to continue. We don't purchase tobacco anymore for our service users. We used to. It's the reality of it. We did. The patients that didn't have leave, we'd go buy them tobacco. They could smoke it out in the garden, but we stopped that. It's still on our community meeting agenda. It did take, it somehow got lost for a few weeks, but it's back on there. Biggest thing the patient said, if you're telling us to go smoke-free, you need to get the staff to get on board with this. And they asked us, please don't roll tobacco or have cigarettes in the office. And it still happens. If somebody's sitting in a chair, it's usually they'll see me pushing them into the little cupboard to get them out of the way. But it's just something they've said. They're getting riled up. If you're telling us we can't have a cigarette on the ward, there's somebody rolling tobacco right in front of my face. Smoking jackets, not like the Playboy Mansion, but it is said that if for women who smoke and other partners, women who are pregnant and if their partner smokes, how they should wear a different jacket. So we kind of took that approach with staff. If you're going out for a cigarette on your 20-minute break, which is meant to happen, but if you're going out for a cigarette, can you please just not wear the jacket you wore outside back into the ward because it's going to smell of smoke. And staff have done that, and it has been quite helpful because sometimes people come into the office and the smell is just hits you, and they take it off so the smell's not there as much. So since we went smoke-free, we've only had one incident where a patient had a lighter in his room. So the lighters were in the clinic, the tobacco was in the airlock. Looking back on it, I don't know why we did that, but we did. We didn't have them all together. And now our tobacco and lighters are stored in the airlock. So it was just a staff member, it was a bank staff member, forgot to get the lighter back off a patient. Simple solution, lighters and tobacco are now kept together. We have a sign-in, sign-out system for when they go out and leave. More recent problem, because our patients are allowed to smoke an escorted leave, we promote leave so much with our patients, but their leave is being split into 2 minutes per, 2 30-minute leave periods per shift. So if you've got a patient, they've got 2 30-minutes per shift, so that's 4 periods of leave a day. They're smoking 4 cigarettes as quickly as you can imagine, then back onto the ward, back out maybe an hour later if the staff can facilitate. And the staff are really good. The staff will get them out on leave. So that's something we're looking to change. And thankfully, actually, we started changing that since yesterday. We spoke to the medical staff last week and said it's not helpful. It's taken up too much staff time. And the patients, the therapeutic benefit of the leave, their personal leave is gone. So yesterday we stopped that for a patient who requested it. So we're just kind of going to move forward with that now. We've had a couple of patients vaping inside. One of them was in a very large room in our lounge, and the vapes that they use are the ones with the tanks, so you get that massive cloud that just lingers, basically. And the other one was actually just on Sunday, just gone. Patient set it off in his bedroom, went down, I'm sorry, I didn't do it. But we know our patients are vaping in their bedrooms. It's like when we were smoking, they were smoking in their bedrooms as well. It's the reality of it, but it's very hard to police, and it's just something, we're not going to take the vapes off them. So it's just a problem that we've come across. With regards to the cigarettes smoked by our patients, so we have 5 patients on our ward at the moment who were there before we went smoke-free last April. Combined, the 5 of them were smoking about 200 cigarettes a day before going smoke-free. When we went smoke-free, that went down to 15, and that was literally just 2 patients that were smoking the 15. And now it's gone back up to 37. So the other 3 patients, after we went smoke-free, were abstinent. They had gone to nothing.